Does the pill cause infertility?
That's a real worry for lots of women. And they've heard lots of different stories and things. It might take a little bit more time for cycles to come back, a couple of months, but it will not affect anything long term.
If you've ever wondered what method of contraception is right for you, then this conversation's for you. Today, we'll be exploring all forms of female contraception, what they are, how we use them, their effectiveness, and all those kind of things. So stay tuned. This is Patient in the Room. I'm joined today by Dr Priyanka Patel, a consultant gynaecologist working at London Gynaecology. She specialises in all things female health. Welcome.
Hi, Megan. So nice to be here.
Contraception has completely transformed reproductive health since, its initial kind of outbringing into the world. There's more options than ever before today, from daily pills to implants to coils, all that kind of stuff. But despite this, I do feel like so many people are confused, like what their options are, what's right for them, and it just feels like a little bit of a minefield.
Yeah.
So I thought today we could start with, what do we actually mean when we say contraception?
So when we talk about contraception, we are trying to prevent pregnancy in the simplest form. So if you don't want to get pregnant and you are sexually active, then it's advisable to be on some form of contraception.
What contraception types are available for women today?
So broadly, we have the non-hormonal contraceptives and the hormonal contraceptives. And in the hormonal contraceptives, you've got the combined methods, which are a combination of estrogen and progesterone. And then you've got the progesterone-only methods. So these are kind of your main groups that we're thinking about.
And what's the difference between the progesterone-only and the combined?
Good question. So the combined methods have estrogen and progesterone, and the progesterone only have progesterone. And basically, if you're you could be eligible for either the combined method or the progesterone only, but the combined methods have slightly more risk with them. So if you have certain medical conditions, so if you've had a clot in the legs or the lungs, you wouldn't be put on the combined contraceptive methods, but you could still use the progesterone-only methods. And I think we'll come on to that, but I can talk about the differences. They're quite different in the way that they may control your bleeding. That's probably one of the biggest differences in terms of their effect. But why you would use progesterone-only may be that you can't use the combined methods.
One of the biggest concerns people have is hormones. What exactly does hormonal contraception mean?
So hormonal contraception means that it contains hormones, and the hormones that we're speaking about are a type of estrogen and types of progesterone. So generally they all have quite similar estrogen in them if they're a combined method, but they have different types of progesterone in them. So we have quite a few different types of progesterone, and they can affect ladies differently. So with a combined pill, you'll have the same amount of estrogen, same type of estrogen, but the estrogen can be 20 or 30. So 30 estrogen is kind of the typical pill. Some of them will be low dose 20, and we have a few that are slightly higher at 35, but it's the same type of estrogen. But then when a patient comes and one type of combined pill is not suiting her, so maybe it may be affecting her mood, we might try a different type of combined pill with a different progesterone in it. But the two main hormones we're speaking about is estrogen and progesterone.
What are the methods of contraception that are hormonal?
So with hormonal contraception, you have, with the combined contraception, you've got the pill, you've got things like the vaginal ring, you've got the patch. They're your main combined contraceptives. With the progesterone-only methods, you've also got pills, but then you've also got the implant, which is a subdermal implant, just goes under the skin. And then you've got we've got 3 types of hormonal coil. They only contain progesterone.
If someone wanted to avoid hormones completely, but still wanted to use contraception, are there options available for that?
Yes, less so, unfortunately. And it's a very common request that, women want to have something understandably without hormones, without the risk of side effects from hormones. And then your main methods are barrier, so condoms, diaphragms for ladies. And then the main long-acting reversible contraceptive that we have, which is non-hormonal, is a non-hormonal coil, which is very effective and quite popular in good number of patients.
And why would someone kind of choose the hormonal birth control over non-hormonal?
One of the commonest reasons that they may do that is if their periods are heavy or painful as well.
Mm-hmm.
So if they come to me and they've got heavy and painful periods, then I would normally say to them that something like the copper coil probably won't be such a good idea for them, because the copper coil can potentially, it's an excellent form of contraception, but it can potentially make your periods heavier or more painful. So it wouldn't be ideal if you've already got heavy, painful periods. So for manipulating periods, making your bleeding lighter, less painful, or delaying periods or having control of your bleeding, the hormonal methods are better.
And I guess, like, do women go on contraception not just to kind of prevent pregnancy, but
Absolutely.
it can be controlling when your period starts, which, I mean, we've all been on holiday and kind of wanted
to avoid your period.
Exactly, yeah.
Yeah, no, absolutely. So we use it. So gynecologically, we often use hormonal contraceptives. They may be being used for contraception as well, but we often use them to help with periods. And actually, that you would often use them when a lady or a patient is not sexually active but wants to control the bleeding. The most effective methods are hormonal, medically speaking.
In terms of kind of starting contraception, is there a minimum age? Is there a maximum age for starting?
So no minimum age, but if you're using it as contraception, then you would want to check that the teenager is sexually active and there's a risk of pregnancy, so it's ovulating every month. And if there is, then there's no minimum age, and you can start contraception at any age, as long as you've obviously explained everything carefully.
And when you're starting contraception, what does that journey look like for someone? So they've gone to see their GP, I assume.
Yeah.
They are sexually active. They would like to kind of go on a form of contraception. Are they kind of talked through each of the different options? What might work best for them? If they are, younger, would a parent be expected to be there as well?
Ideally, in terms of explaining to them, ideally as a medical professional, you'd be explaining all the methods available. But like you were saying earlier, there's so many misconceptions. And maybe one method that perhaps a clinician's more familiar with may have been encouraged or pushed without telling them that these are the different forms, these are the pros, these are the cons. Whether a parent has to be there or not, they don't. So as a medical professional, you look for phrasal competence. You just make sure that teenager can understand what you're saying, can weigh pros and cons up, and can make an informed decision. And they don't need their parents' consent to say yes to contraception.
At any age, someone could go without a parent or guardian and access contraception.
They could go at any age, and they should, obviously, because it would be ideal if they spoke to somebody and shared what their requests and wishes were. But if the medical professional felt that there was any reason to worry, so if they are 13 or under, then there are obviously worries about them being sexually active. And then there are other safeguarding implications that you would act on as a medical professional, as you would even older than that. So if you had those concerns, if they were above 13 and you didn't have concerns about coercion, about safeguarding, then you could safely prescribe contraception to them according to their needs and medical history.
And is contraception free in the UK?
Yes, we're so lucky. It's free in the UK. And I have patients coming from elsewhere. And, they sometimes are amazed that, you can go to a sexual health clinic and get contraception for free, which is brilliant.
Are there any concerns towards health if you're starting hormonal or non-hormonal contraception when you're really, really young?
So there are no long-term implications. So lots of patients worry, lots of women worry that, look, if we start so early, I've been on the pill for so long, do I need to worry more? And actually, the risks of hormonal contraception are so low that it isn't that if you start at 16, that by 26 you have to be more worried. There are some risks with hormonal contraception that will go up slightly with the time that you're on it. So the combined methods have a very small increased risk of things like breast cancer, and that the longer you're on something, the slightly increased risk you have. But we're talking very low baseline risks, and there's advantages. So the combined pill reduces risk of ovarian cancer. It reduces risk of colon cancer. So there's endometrial cancer, actually. So there are lots of advantages of hormones as well. And nothing that somebody in a young, fit patient who doesn't have significant medical history, these risks are very low. So the risk of clots in the legs and the lungs is very small. So it's against your baseline risk, and you don't have to worry too much that, do I need to start worrying after being on it for a period of time? In the past, we used to say above 40 that with combined oral contraception, we were a little bit cautious, and we were starting to get patients off it because it can raise risk of clots, and age does that as well. And cardiovascular risk goes up as age goes up. But actually now we use it until 50 safely. Above 50, we tend to come off the combined methods, but then we would have the progesterone-only methods for as long as the lady is until she reaches menopause.
And in terms of the effectiveness of all of these contraceptions, is there, the gold standard, this is the best one in terms of effectiveness?
So the hormonal contraceptives and the non-hormonal coil, they are all extremely effective. So they are all above 99% effective. Nothing is 100%. So sometimes patients are surprised when I say to them, if you have a coil, you always say to a patient that if a bleed is very unusual or you have strange pain, still think about doing a pregnancy test because of that tiny risk and the increased risk of things like an ectopic pregnancy if you get pregnant with it.
Yep.
But that's a very small, very tiny risk. So these methods are all above 99% effective. But the difference between, say, the long-acting reversible contraceptives, and when we're thinking about that, we're thinking about the coil, the implant. These are methods that the user does not have to be remembering and taking something every day. Their actual effectiveness and their known effectiveness are the same. Whereas something like the pill, the actual effectiveness, the known effectiveness is over 99%. So if you take it regularly, you're meticulous, you don't miss a pill, then it's very, very effective. But in reality, most of us just don't do that. Yeah. So the effectiveness of the pill typically will drop to about 91, 92% because of women missing a pill, not taking the precautions if they have missed a pill, things like that. So that's why these long-acting reversible contraceptives are more effective. It's just because the patient doesn't have to remember anything.
And in terms of remembering to take the pill, is, if you're trying to take it at 8 a.m. every day, and then suddenly it's 10 a.m., you've forgotten, but you take it at 10.
Yeah.
What's the time frame for it becoming less effective?
So different pills have different time frames, but most pills, 24 hours is fine with the, some of the combined pills. Sometimes it may be 12 hours. Some of the older type of progesterone-only pills is 3 hours. So those are quite, 3-hour windows, quite short.
Yeah.
But then a lot of the newer progesterone-only contraceptives that also stop ovulation, and we'll come on to the way that these work, but they have a longer window. So usually 2 hours and things won't matter. You've got time.
And in terms of, you kind of touched on how they work there, but if we were talking about hormonal contraception, what actually does that do? Like, why does it stop pregnancy?
That's a good question. And I think we often don't take the time to explain it. And then patients go away using something that they don't completely understand, and they understandably feel uncomfortable. So hormonal contraceptives work in a few main ways. So one of the main ways that they'll work by is stopping ovulation, so stopping the egg being produced every month. Another main method of working, especially with the progesterone-only methods, is a cervical mucus. So the neck of the womb, the mucus there will stop the sperm going up and meeting the egg. And then another method that they may be working by is thinning the lining of the womb. So they're not making the womb, the hospitality of the womb to a pregnancy. It's not as friendly. It won't let a pregnancy, implant there. So they're kind of the main ways that they might be working. And, some contraceptives will be using a couple of the ways. So something like the Mirena coil, it will be producing a mucus plug. It'll be making the lining of the womb thin, which is one of its main actions. And in a proportion of ladies, more so in the first year of using it, but less so as time goes on, a minority of ladies won't be ovulating as well. Whereas the combined methods, the main way they work is stopping ovulation.
And if you're stopping ovulation, so obviously as women we're born with the amount of eggs that we're ever going to have. If we're stopping ovulation, is that kind of a way of keeping our eggs?
Unfortunately not. So it doesn't. So it's not that you will then be able to, if you come off contraception, that your fertility will be better, but your fertility won't be any worse. So I think one of the big things to understand for women is that these methods, they are reversible. They will not be affecting your fertility. It may, with the combined methods, might take a couple of months for your periods to come back because it's been stopping ovulation. Your ovaries have kind of gone to sleep for a while. So it can take a few months for your periods to come back again. And it can take a little bit of time for them to regulate. So lots of times if a lady is on the combined pill or a combined method, I will ask them to come off it roughly around 6 months before they want to start trying for a pregnancy. And I say, why don't you use condoms for that time? Cycles come back, you get your regular cycles again. And then when you're trying for pregnancy, you'll know when you might be ovulating, makes it a bit easier. Other methods, progesterone-only methods, they are even quicker. So when we're taking the implant out, Mirena coil out, we will say that, as soon as we take this out, you could be fertile again. And within a month, a lot of it is out of your system completely. And that can surprise women because they might have had it for, might have had their second implant 6 years on. They think, it's going to take ages for it to reverse. And it doesn't. No matter how long you've been using it for, these are very reversible.
And in terms of side effects for these hormonal contraceptions, what's like a really common side effect that you might see?
So common side effects is probably, especially initially, disturbance to bleeding, because a lot of these contraceptives, if they're stopping you ovulating or they are keeping the lining of the womb thin, they are going to change the bleeding pattern. So even with the combined pill, you have, even if you're taking it 21 days, that you take the pill every day and then you take your 7-day break or 4-day break, during that break, that bleed you have is not a true period. It's what we call a withdrawal bleed. So initially, one of the commonest things you'll see is that bleeding will become a bit erratic. And just to let the patients know that to expect that, because it can be quite disconcerting. If you've had regular periods your whole life and suddenly your bleeding's all over the place, you just wonder what's happening, and often it will settle. With some progesterone-only methods, they don't tend to give the regular bleed like the combined methods do. And that can be a reason to decide between them as well. So some women, we're all so individual. Some women like having a monthly bleed. And if they really like having a monthly bleed, then the progesterone-only methods may not be for them because they are less likely to give you that regular bleed. Whereas the combined methods, you can have a regular bleed if you want to. But that's one of the common side effects we see. And then hormones can potentially cause mood changes, skin changes, bloating. So most of the methods, a lot of women worry about weight gain, but only the Depo-Provera injection, which is a progesterone only, has been associated with some weight gain, and that too, marginal, couple of kilograms, not huge, not stones or anything. But the others can make you feel a bit bloated sometimes, and they haven't been associated with weight gain, but they can make patients feel bloated. Breast tenderness, mood-related changes sometimes. So these are some of the commoner hormonal side effects that we'll see.
I saw something online, and I've had numerous friends kind of say this as well, where they've been on the combined pill, and they are kind of saying that actually it's maybe not weight gain, but they're like holding more water, like water retention.
Yeah.
Is that actually a side effect?
Yeah, that can be. So it's a bloating that you feel because, like before a period, sometimes women feel a bit more bloated. The hormonal contraceptives can do that. Often the side effects will fade. So often you'll have more side effects in the first 4 to 6 weeks or so, and then they will fade away. So a lot of times I often say to patients that if you can give it, say, at least 3 months, that's a good time to see how you're actually going to do on it. And for some of the progesterone-only methods, like the Mirena or the implant that can cause irregular bleeding, we normally advise that if they could give it 6 months, that's brilliant. We can give something to help with the irregular bleeding because if it's really becoming troublesome. But then by 4 to 6 months, you'll kind of know how you will be on that method long term.
And is it quite common for people to swap what contraception they're on?
Yeah, absolutely. And they should. Because unfortunately, as yet, who knows how it will change, but as yet, we can't do a test to see what will suit somebody. So a lot of it is trial and error. And actually taking the time to do that trial and error. And that's hard. We're all busy. And, you try one method. If it doesn't suit you, you might try one more. And then a lot of patients might feel fed up. But to try and say, we've got so many different methods. If you want reliable contraception, we should be able to find something that suits you. But it may be a bit of patience and trying things out. And then taking the time may mean that you'll find that method that suits you the best.
And when we're kind of talking about all these different methods, there's obviously so many different brands of, all of them, I guess.
Lots.
How do you decide which brand of contraceptive pill to put someone on?
That's a good question. There's so many different brands, but many different brands will have the same hormones in them. Mm-hmm. So something like, a pill that a lot of ladies may have been started on is microgynon. Mm-hmm. The type of progesterone it has in it is a type of progesterone that's slightly safer. So there's different types of progesterone, and some of them may have a slightly increased risk of clots, just very slightly. So microgynon is a commonly used kind of first-line pill. And then there's another one called rigavidon, which is exactly the same. It's the same progesterone and it's the same estrogen and there's the same amounts. So the trade name that you're using, the brand name, doesn't matter. It's what hormones are there. And that's why if a patient's come from abroad, they'll bring something and we won't have the same brand name, but we'll have exactly the same pill. And that can be a bit disconcerting because if a patient's been on something for ages and, it suits them and they like it, it'll take some explanation to say this is exactly the same. It's just called a different thing.
And when you're having that initial conversation with the woman, do you kind of talk about their lifestyle and things like that? And that's how you kind of work out which contraceptive might suit them the best?
Definitely. And a proper contraceptive consultation can take a good amount of time. So if you're actually exploring properly with her what her lifestyle's like, medical history, what her preferences are like in terms of periods, and explaining to her all the methods available, that takes time. And I think as clinicians, we need to take that time for that, especially for that initial consultation. And often we may not. Even if time is short, if you kind of signposts them to, there's websites and apps and contraceptive choices, sex-wise. These give often really good algorithms as well, so they can follow them through, and you can answer questions, and then you can try and get to the right contraceptive for yourself. But really important to go through all of the background in that.
And so I feel like for a lot of women, this is likely the case. But you're in secondary school. You've kind of maybe had a period for a year or something like that.
Yeah.
And you're kind of taken to your GP with your mum, or your parent, and it's kind of the parent that wants to put that child onto contraceptive.
Yeah.
What advice would you give for that teenager?
So we spoke earlier about teenagers, that they don't need their parents to come with them.
Mm-hmm.
But we would always encourage them to speak to their parents if they can, because to get that support is just so important.
Mm-hmm.
But if it was the other way around, that they came with their parent and the parent might have a desire or might want something for their child, which, I have a teenager, we're always guilty of thinking that we know what's best for them. You always want to try and speak to that teenager alone.
Mm-hmm.
That's important as well. And usually parents don't mind, because they understand and they actually want the best for their child.
Mm-hmm.
And they want the child to try and share things with you that they might not, to keep safe, really. But you would try and come to an understanding between them.
Mm-hmm.
So I would always I would bear in mind what the parent's saying, try and speak to the teenager alone, find out what their worries are, what their concerns are. Often there might be really difficult periods, and the mum or the dad wants their child to be pain-free, have better periods, and the pill can be so effective for that. But the teenager might have their own worries about it, to try and speak to them. And then if they are sexually active as well, then that may be something that they've shared with their mum or dad, or it may be something that they haven't. But then it's so important to speak to them alone, because if they're just using it for periods, then missing pills, apart from making their bleeding erratic, won't be the end of the world.
Yeah.
But if they're using it for contraception and you don't explain to them that if they don't take it regularly, there's a risk of pregnancy, that's so important. And if you don't explain to them that the pill will not protect against sexually transmitted infections, so some of them may think that they're protected against everything, but they're not. So only condoms will protect against most sexually transmitted infections. But just explaining that when they're alone is so important, depending on how much they've told their parent, and just clarifying what they've shared with their parent as well.
Yeah. And if someone has kind of gone on to the pill when they were 14 years old, they've been on it for about 10 years, they fancy a change for whatever reason.
Yeah.
Is there kind of like a time frame where they have to come off all contraceptive before trying a different one, or can they just jump straight to a different contraceptive?
They can jump straight to a different contraceptive, and there's no advantage to coming off, giving your body a break.
Mm-hmm.
Lots of women worry about that.
Yeah.
That should be, have a bit of a break off hormones.
Mm-hmm.
But unless you don't need contraception for a period of time, and obviously if you don't need contraception, then don't use hormones if you don't need it.
Mm-hmm.
Definitely you can come off. But if you want a reliable contraceptive, the best way is to move from one to the other. And we can do that for all contraception.
And in terms of kind of like long-term contraception, so from my understanding, you've got the implants and you've got the coils, and they're kind of like the longer forms. How long would an implant last someone?
So an implant lasts for 3 years. The coils, it depends on which one you have. So the non-hormonal coils, there are ones that last for 10 years. Some of them last for 5 years. And then the hormonal coils, we now have 3 different types. One lasts for 3 years, one lasts for 5 years, and the Mirena has recently, or the equivalent of the Mirena contraceptive, has been now licensed for 8 years of use. So it's a long time.
And why might someone want to kind of use these longer forms of contraception?
A lot of times for convenience. So a lot of times they are so convenient, you can forget about them. And we're all busy. So taking a pill every day is actually quite an undertaking.
Yep.
And then to worry when you've missed one that, oh my goodness, what do I need to do now? Do I need to use condoms? For how long? Do I need to miss my pill-free week? And things like that.
Yep.
So convenience is probably one of the commonest reasons. But then the other one can be low hormones. So something like the progesterone-only coils, they have very low doses of levonorgestrel, a type of progesterone. So if women want a low dose, they can be so ideal. And then probably the third reason may be difficult periods and wanting something convenient. So the Mirena is one of the most used hormonal methods for controlling periods very successfully, very well.
Does it hurt to get these implants and coils done?
That's such a common worry.
Yeah.
And so it shouldn't hurt, but it can be uncomfortable, but it should be, we're thinking about discomfort for a couple of minutes.
Yep.
And that's why it's so important to explain it as well. So lots of patients are really worried about how painful it is. They might have heard of horrible stories, and I always take my time to explain to them. So the implant is such a simple insertion. It's minutes, like a minute to put it in. The initial bit, the thing which is most uncomfortable is putting the local anesthetic in. So the local anesthetic for a minute or two will sting. So that's the most you'll feel. And then actually, when we're putting the actual implant in, it's less than a minute. You might feel touching, pushing and things. So really very, very straightforward. The Mirena or the progesterone-only coil insertion or the non-hormonal coil insertion. So both insertion processes are exactly the same, very similar. They're slightly different techniques for clinicians, but to what the patient feels, very, very similar. They can feel a little bit more invasive because you'll have a speculum, like when you have a smear test, or if a patient hasn't had any smears yet, if they've had abnormal bleeding, or they've had a check done for abnormal discharge. So there's an instrument called a speculum that will gently pop inside the vagina. We get a clear view of the cervix. And then I have a very low threshold for using local anesthetics. So unless a patient says to me that they specifically don't want it, I just think, make it as comfortable as possible. Why not? Why would we make anything more uncomfortable than it needs to be? And if you haven't, there's a common misunderstanding that if you haven't had a pregnancy, so if you haven't had a normal delivery, that you may not be able to get a coil. That's absolutely not true. We put the coil in so many patients who have never been pregnant, and it's so straightforward. And, usually you will have no issues with it. But what we can do to make it easier is use local anesthetic. There's gel, there's an injection, which is more effective. There's spray that you can use, lots of different ways. And that just makes the neck of the womb, the cervix, you may have to gently just open it up a little bit. And that can make that feel much more comfortable. Then when we put the coil in, the coil sits at the top of your womb ideally. So it sits at the fundus. When anything touches the top of your womb, often it's a little bit uncomfortable, but probably for 10, 15 seconds. And then in my practice, I will do a scan afterwards, check it's in a good position. And then the next few days sometimes may be a little bit uncomfortable. It's often as the womb is adjusting. So women are so variable. Some women have it, they're fine, they walk away, and they're feeling absolutely fine from moment one. Other ladies might feel a little bit faint, a little bit sick initially. They might want to rest for a little bit. We'll get them a nice hot drink, and very quickly they'll feel better. And sometimes in the next few days, they might have period type of cramps. So I'll say to them, use simple painkillers. But then after that, you shouldn't even be aware it's there.
And is there a risk of infection with these two methods of contraception?
So when you put the implant in, there's a tiny risk of skin infection because you're making a very small incision. But to be honest, I don't think I've ever seen that. So, we advise what to look out for, but the risk is so low. With the coil, there's a risk of pelvic infection because you're putting something from the inside the neck of the womb into the womb. But we now know quite conclusively that it's linked to the risk if they already have an infection.
Mm-hmm.
So if the patient is at risk of a sexually transmitted infection, you would always want to screen them first, or you screen them and cover with antibiotics. But most often, if they've had a recent screen, regular partner, not at risk of infection, then the risk of infection with a coil insertion is very low. And we don't give routine antibiotics. You don't need to. But we tell them what to look out for.
And in terms of long-term use for hormonal contraception, is there a risk associated with long-term use?
So there's no significant risks that are associated with long-term use. Things like the very slight risk of breast cancer I mentioned before with the combined pill, the longer you're on hormones, the risk goes up slightly. So that risk is linked to risk of being on it. But it's a very minimal risk. And for most fit and well young ladies, that risk is very, very low. In fact, other risks are much more significant for breast cancer. And I go through the same conversations for ladies using hormones in HRT, that the risk of being overweight for breast cancer is much, much more. So we're putting these risks into kind of perspective. But other risks, there's no other risk of it in terms of that the longer you're on it, that's a worry. You don't need to worry. And when you come off it, it's a similar process, whether the person's been on the pill for 15 years or 2 years. I normally say with the combined pill, it can take those few cycles. So it can take sometimes up to 6 months for their cycles to come back. And then also it can unmask things when you come off it. Mm-hmm. So if a patient has something like polycystic ovarian syndrome, where they're having infrequent periods, they might have started the pill so early that they can't remember what their natural periods were like. But when they come off the combined pill, it'll go back to what their natural cycle is like. So if they are infrequently ovulating, like with something like PCOS, they may have infrequent periods, but that's not because of anything the pill's done. It's just that the pill is giving you artificial bleed every month, and now you're seeing what your natural cycle is like.
So talking about coming off of hormonal contraception then, what would be normal for someone to expect?
So it would be normal for your cycles to take a bit of time to come back, more so with the combined pill. But with the progesterone-only methods, you'll often have, so if you take out a coil, you might have a bit of a bleed at that time. When you stop hormones, sometimes you'll get a withdrawal bleed. You'll often do that. So you've stopped your hormones and then you'll get a withdrawal bleed, which is not really a true period. It's just an artificial bleed. And then it'll take your cycle is probably going to be erratic for sometimes up to 6 months. It can be. But with the progesterone-only methods, often fertility will come back very quickly. So periods, ovulation, everything will come back very quickly by about a month.
And for someone who's kind of hitting that 6-month mark, having come off hormonal contraception, and things are still not normal, is that concerning?
It's not concerning. So occasionally some women are a little bit more sensitive. So I have seen some ladies who've been on the combined pill and it's taken a year for their periods to come back to normal. It's never irreversible. None of these methods are irreversible. And I spend so much time trying to reassure patients that, I promise you this hasn't done anything permanently. But it's almost that I think their ovaries were so sensitive. They've kind of, haven't been ovulating for so long. They're taking a bit more time to wake up, really. So occasionally I have seen it taking longer, but generally it'll be by about 6 months, usually their cycles will be back. So nothing worrying, but I would say that if your periods haven't come back and it's 6 months on, and especially if you want a pregnancy, it's a good idea to see the doctor. We can do an ultrasound scan, we can do some hormonal blood tests, and we can just make sure that everything else is normal. But the pill or whichever hormones you've been on wouldn't have done anything permanently.
When they do come into clinic, maybe like it's still not normal after a year, is that when those red flags will kind of be ringing for you?
Yeah, so that'll be a time that we should definitely be investigating. So even by about 6 months, I think it's reasonable to go and see your GP, come and see a gynecologist. We can do some further testing. Most often, I've done it and it's been absolutely fine. Sometimes you'll see things like polycystic ovaries, and then they're not having their regular periods, and then you'll have a reason for why they're not. And even then, there's so many solutions. So nothing worrying, nothing to be alarmed, but definitely to check out.
And so for hormonal birth control, if someone was wanting to get pregnant, you'd recommend around 3 months?
Yeah, so usually I say for the combined method, so if they're on the combined pill, I often say that maybe coming off around 3 to 6 months before you want to start trying for a pregnancy, and then using something like condoms in the meantime. So it wouldn't be a disaster if you got pregnant, but just giving it a little bit of time, I think is a bit nicer, because otherwise if you come off a combined method, and it can take a couple of cycles for your periods to come back, and then you're trying for a pregnancy, but you don't know where you are, you don't know when your period was, and then you don't know when your fertile time is, when is 2 weeks before period when your cycle hasn't come back regularly. It can just make trying for a pregnancy that much more stressful. And then that's when women will worry that has the combined pill done anything permanently. It takes a couple of cycles for it to come back. With the progesterone-only methods, you can leave shorter time because usually your fertility will be back quicker. So as soon as I take the coil out, it's usually that a lady wants to start trying then. And it's not infrequently that they'll get pregnant very quickly. And even with the combined pill, I've had so many patients who've got pregnant very quickly. So it's not that everyone's cycle will take time. And for them to remember, I think women are more surprised when their fertility comes back because somehow they think it's going to take a bit longer. So, just warning them as well that now you could get pregnant anytime if you're not using anything. And you can get pregnant without having a period. So because you can ovulate, so you can produce the egg and your period will come 2 weeks after that. But if in the meantime you have fertilized that egg, you could become pregnant without having a period. So, sometimes these things can happen really quickly. But just as long as the patient just realizes either way that, it can take a bit of time. On the other hand, it may not.
I've heard some women say as well, when they have come off hormonal birth control, that they feel much more like themselves.
Yeah, definitely. So sometimes hormonal methods can affect mood. And on the other hand, we can also use it to treat things like PMS, premenstrual syndrome. So some women are very sensitive to the normal and not uncommonly very sensitive to the natural cycles, and they'll get PMS before their period. And we use the combined pill as one of the most effective treatments for PMS. We often use it back to back though, rather than taking the break for the bleed. But also sometimes being on hormones can affect their mood. I think I tend to see that more with the combined pill. And then they do feel that once they're off that, they feel better. And then actually, of course, if they feel better off that method, then we need to find another method that suits them better.
I just wanted to touch on there. You kind of said that when you're on the combined pill that you can just take it back to back.
Yeah.
Is there a limit to how many times you can take that back to back?
No limit. So a while back, we used to advise that the way to take the combined pill was 21 days, 7 days break. But that was mainly done because women often like having a period every month. So this kind of mimicked that false, this is a false bleed, but it mimicked that. And lots of women liked having that. But there's no reason that you have to have that. And there's no advantage to doing that. It depends on if that's the way you want to take the pill. So now when we give the combined pill, at the risk of completely confusing a patient on how to take it, you can say to them, you can actually take it like that. You can take your 7 days break. You can take a shorter 4-day break. You could tricycle it. So you could take a couple of packs together, then take a break. Or you could take it continuously and you don't need to take a break. In the past, we used to worry that is that too much hormone, in a year? But actually, it's been shown a while back now that that's not the case. Absolutely safe. You can do that. But what you might start to get is a bit of breakthrough bleeding. So if you take it continuously, you might start to get breakthrough bleeding. And if you do, which is a bit like a period, you may then say to the patient, then take your 4-day break. Otherwise, you may start to get irregular, annoying, bleeding. But no risk to doing that. You can safely do that.
And I wanted to touch on emergency contraception as well. What options are available in terms of emergency contraception?
So there are 2 main methods of emergency contraception, orally and coil. So the same copper coil, the same non-hormonal coil that we use for contraception is a very effective emergency contraceptive. But you have to put it in within 5 days of the earliest that you could have ovulated in that cycle. So, and if we can't tell when you may have ovulated, then it's within 5 days of having had unprotected sex. But the coil, the emergency coil, is the most effective emergency contraception, and that's also not completely understood. So lots of women will be familiar with the oral pill, and there's 2 main types. One is, so Ella-1, which is probably more familiar, that a name that everyone knows it by, is more effective than Levanel, which is the other type of oral emergency pill. Slightly more effective because it can, both the pills work by delaying ovulation. That's the way that they stop you becoming pregnant. So they try and delay you producing the egg so the sperm can't meet the egg then. But Ella-1 can work when the surge towards ovulation has started, whereas Levanel doesn't. So one of them is very slightly more effective, but they both work that way. But if you've already ovulated that cycle, they're not going to do anything. And that's very misunderstood. So sometimes I will see patients who are using oral emergency contraception as their contraception, but they won't understand that actually it's the reason why it's not nowhere near 100% is because it will only work very well at certain times in your cycle. But they're your 2 main methods of emergency contraception.
And once you've taken, so obviously with the coil, that can then sit there for the next 8 years?
Yes, 10 years sometimes, yeah.
And with the pills, what would we expect to happen after taking one of those pills?
And that's a good question because we often advise patients because they'll worry if their period doesn't come. But we'll advise them that the next bleed will likely not be your normal period because you've taken hormonal emergency contraception. So it can delay your period or delay your bleed, which actually can cause the most worry because they're worried about pregnancy and then their period hasn't come and they think, oh my goodness, I'm pregnant. But no, you've taken the emergency pill and what that's done is that's delayed your ovulation and hence delayed your next period. But your next period or bleed could be early, late, it could be unusual. If there is anything unusual or the bleed is late, then obviously do a pregnancy test.
And so I feel like some people, there might be a bit of misconception around this, but once you have taken that pill, you're not going to immediately start bleeding?
No, often not. So you're not immediately going to start bleeding. Sometimes it can cause irregular bleeding. So sometimes a patient may have a bleed or sometimes the period is due anyway. So really the pill may not have done anything. You've already ovulated, the period's due, you get your normal period. But definitely it can definitely delay bleeding and it can affect bleeding and you may not have a bleed straight away.
We're coming to the end of our chat here. I've got a few kind of like myth-busting, frequently searched online, just to kind of provide a little bit of clarity to people watching this. So does the pill cause infertility?
No. So none of these contraceptive methods cause infertility. And that's so important because that's a real worry for lots of women. And they've heard lots of different stories and things, but I spend the time reassuring them that none of these methods will affect their fertility. It might take a little bit more time for cycles to come back, a couple of months, but it will not affect anything long term.
And is it dangerous to stay on contraception for many, many years?
No, it's absolutely safe. And the clinician should only be continuing the contraception if it's safe. If there's reasons to come off it, we as clinicians should be advising you. So something like the Depo-Provera injection, after a number of years, it can start thinning the bones. So a clinician should be telling you that, it's been 2 years, you've been on it, I know you love it, but actually there are some better methods. Would you consider moving to something like the implant or, giving you the choices? And it's always a balance. So it could be that the patient wants to continue something for a bit longer, but you're balancing out the good and the bad. But nothing that you're on that you've been continued on under the supervision of a clinician will be bad for you. Things like the combined pill, we should be monitoring blood pressure because it can affect blood pressure. It affects cardiovascular profile, so we keep an eye on risk factors. If you are a smoker above a certain age, we shouldn't be continuing the combined pill. We might shift you on to the progesterone-only methods, which are safer for you. But anything that you make sure that you're obviously seeing somebody regularly, but as long as you are, none of these methods being on them for what feels like forever will have any harm.
And does the coil move around inside your body?
So it doesn't. That's a good question. I'm glad you asked that. The reason we used to call it, what can happen is when we put the coil in, there's threads that come out of the cervix in the vagina, and we normally cut them 2 to 3 centimeters. We used to call a coil, so when we couldn't see a coil, we would say sometimes you'd say, oh, the coil's a missing coil or non-visible coil. But actually what's only happened is that the threads have got pulled up into the womb. The coil is there, but the threads have got pulled up into the womb, which is irrelevant until you want it removed. The threads are just an easy way of removal. And it just means if the threads have been pulled up, it just means that we might need to go a little bit deeper to get the coil out. But the coil is still sitting inside your womb. And actually, officially, the name was changed a little while ago to non-visible threads. So we're not supposed to be saying, missing coil and things like that, because it can make women worry so much that where is this missing coil gone? The time that the coil can be outside the womb is if there has been a perforation. So a perforation is where we make a small hole in the womb. So anytime you're doing a procedure, when you're putting a coil inside the womb, there's a very small risk, probably around 1 to 2 in 1,000, that you go through the wall of the womb and then the coil is outside the womb and it doesn't move around in the body as such, but it's in the abdomen. And very rarely this will happen. Unfortunately, that's a real worry. And I think a lot of times that's, there's horror stories and things. This is extremely rare. And with, and also as clinicians, we do this procedure day in, day out. And we will often, and that's why at London Gynaecology we do, but we always scan afterwards. So we scan to check the position of the coil to make sure it's exactly where, you expect it to be. And usually as an experienced clinician, you'll know when the coil has gone in fine, it's all fine. But we do a double check as well. So there will be no chance of that. We also offer a coil check at 6 weeks because there is a 1 in 20 risk that your womb can contract and the coil can be expelled out. So we just check that hasn't happened as well. But no, the coil won't be floating around in your body, and neither will the implant. So there's, these horror stories of these extremely rare events that the implant has gone into some kind of vessel, and then the vessel and an implant has been found in the lungs or something. These things should never happen. So when we put the implant in, it's subdermal. You make your patient feel it, you feel it. It's just under the skin, doesn't move around anywhere. And that's why the placement should be subdermal.
And last question before we wrap up, but can you use a period cup when you have the coil?
Good question. Yeah, you can use a period cup, and that's fine. And it's not a reason that we say not to. Occasionally, the risk with the period cup is because the period cup is just going near the cervix and the threads are there. What you can inadvertently do is pull the coil out. So in the same way that we would remove a coil, and coil removal is so easy, if the threads are there, you literally just take the coil out holding those threads, and that's why the threads are there. So rarely you'd mistakenly catch onto the threads and take the coil out, but it's very unlikely. And often what happens with these threads, they kind of get tucked in over time. So it's not something we see commonly, and it's not something we say you can't use a period cup if you've got the coil in.
And for someone listening to this conversation, what's one kind of thought you'd like to leave them with?
I hope that the thought that I'd like to leave them with is to discuss contraception with a clinician who has an interest in it, who has understanding of it, because I think that they may be surprised with some of the methods that are available that they didn't even consider. The number of patients I've had who've had coils quite late and said to me, I wish I'd known that this was available 10 years ago. Why wasn't I offered this? It's a shame. And I think have the discussion. It doesn't mean you need to use any of them. You know, you could decide that actually you don't feel comfortable with any of them, and no clinician should be trying to make you or trying to encourage you to use one method or the other, because it's a complete patient choice. But have the discussion and with a clinician rather than on the internet. So I think sometimes when you look up, you know, some of these things, you hear these horror, rare stories, and they are not the truth. That's not what happens in reality. And we will always give you a balanced view of the pros and cons, and you can make your decision.
Amazing. Well, Dr. Patel, thank you so much for coming down to chat to us. I found this conversation really, really interesting. I had no idea how many different options there were.
Perfect.
Thank you.
Well, thank you so much. It's been a pleasure. Thank you.
If you enjoyed today's episode, please follow and share Patient in the Room wherever you get your podcasts. We'll be back soon with more conversations.